Everyone, thanks for joining us tonight. I was just saying on the chat that I hope everyone's had a chance to enjoy the beautiful weather that we've had the last couple of days. It certainly was a long time coming, it seemed, this year. In fact, Toronto nearly set a record for the number of consecutive days without a 20-degree day. We were like a couple of weeks away from breaking the all-time record, and it was nice to see us not achieve that in the midst of everything else that's going on. A long streak of bad weather almost seems desperately unfair. So thank you so much for joining us tonight. This Surfing Knowledge Supper Club was envisioned by UHN and Toronto Life as a partnership to support both our local hospitals and our local businesses. And obviously, we have had to change it up in the midst of the current crisis. If this was going by our original plan, we'd all be sitting in a lovely restaurant right now, enjoying a great chef. Instead, we have I don't know if everyone got theirs, but I'm enjoying a delicious cheese plate from the Cheese Boutique. I'm also drinking some delicious Ontario wine, but I'll try my best to keep that off camera. So, you know, when we started doing these things virtually, one of the things we always said is that, you know, we may be in isolation, but we're in isolation in one of the best cities in the world. And that should make a difference to how we isolate. So thanks again, everyone, for joining us today. And thank you as well for your donations to the UHN, to the Toronto General and Western Hospital Foundation. They're very much appreciated. And I wanted to take a moment, especially to thank Alex Wilson, who's the broker owner at Remax Wealth Builders Real Estate. He's going to be matching everyone's donations for this program, which doubles the impact of your donations. So it's a very generous thing that Alex Wilson has done. Thank you so much, Alex. Why don't you wave for us, Alex?
No problem at all. My pleasure.
Okay. All right. So now I'm going to introduce Dr. Andrew Boozary. Dr. Boozary is the Executive Director of Health and Social Policy at UHN. He's a physician and one of Canada's leading voices in the field of social medicine. And social medicine is just something that I've started to become familiar with since starting this process with UHN. It's a discipline that aims to understand how social determinants of health, things like income and housing and education, influence health outcomes, and then help implement solutions that lead to a healthier society. He's kind of like a doctor for society. Which is, I think it's an amazing thing to be, an amazing program that he's leading at UHN. Dr. Boozary is on the front lines of the city's efforts to protect Toronto's vulnerable populations at this time, especially from the effects of COVID-19. And he is also a co-lead of the Toronto Region's Homeless COVID-19 Response Force. So thank you and welcome, Dr. Boozary.
Thank you so much, Ken, for having us. And again, thank you to Alex and everyone who's making the time tonight and the donation and the support for the COVID response across the city has been really heartening. So thank you.
So as we get rolling, why don't you just tell us a little bit about your background?
Yeah, I mean, it's always nice while everyone's, we can have dinner and just delve into background. I think in terms of, in my training, I guess, in terms of the role of social medicine, I think, there's been, obviously I've had training as I'm a family doctor and take that with a lot of pride in terms of the work that can be done and the ways in terms of having a general view. But further than that, I think way back, I'm again really fortunate to have been born in Toronto. I was born in St. Jamestown, where we grew up. Fortunate to have a family here in Canada and growing up in this country. And I think when you look at how things sort of shape you in terms of the background, obviously like my family's experience has, where we grew up has, and then also in terms of being able to go through training and learning so much from patients, from communities that I've been fortunate to be engaged with and to have time with, has shaped a lot of my views on this. And I've also had some experience of living and working in the United States, so seeing some of the similarities, but a lot of the contrasts in terms of what I think we've always set out at the hope of our Medicare system and what that means in providing healthcare for all Canadians. So I think having that in terms of the background has shaped a lot of that. And I think obviously not hoping to make this a therapy session, so we'll move from that piece. But thanks for the opening table setting.
No, my pleasure. And why don't we talk a little bit about the social determinants of health? I mentioned some of them earlier, things like income and education. What are we learning about how important those things are in terms of overall health outcomes? Both specifically to the COVID-19 crisis and to health outcomes in general.
Yeah, I appreciate the way you framed it in terms of around social medicine or the social determinants of health. And I think you've done a really good job of just articulating really the basics. And these are things that we all know, that where we live, what we eat, the air we breathe, where we work, and the relationships that we have a profound effect on our lives, obviously, but really also on our health outcomes. And I think this is, again, known from as old, a tale as old as time, of understanding just how important health is to well-being, health is in our lives, and that medicine or healthcare is really one part of it. And I think we've seen incredible advances in healthcare over the last few decades. Really fortunate to be working at UHN, where it has been a leader in terms of some of the things that can be done in the medical sciences with respect to lung transplants, to advances in stem cell science, and cardiovascular disease management. So some of the real cutting edge treatments and therapeutics that have taken place, again, over the last 20, 30 years, that have had real impacts in saving people's lives, prolonging people's lives. But when you look at the literature and you look at the evidence base, healthcare is a significant part, but is only a part of what is able to shape people's health outcomes. And we've known this, again, not only from biblical texts. We've known this from the 70s, when there was a royal commission with the Lalonde report at the time, the then Minister of Health. In 1974, 5 or 6 years even after we passed a Medicare system, of a universal healthcare system, our government, our people, our country recognized that even having universal healthcare was only going to be a part of dealing with the health of Canadians, in that there was views around climate change even at that time, in terms of the environment people are living, the quality of the air that people breathe, all the way to issues in terms of employment, income, housing, being major drivers of people being able to have a healthy life. And again, I think we've known this since then, but the challenge has been we've not acted on these things, and not acted them in convincing ways, which is why we see major disparities in the country between Black, Brown, Indigenous populations in terms of life expectancy. And as we can get into it, and on a range of healthcare measures, from access to treatments, access to surgeries, but ultimately we have as a country accepted a healthcare gap and an outcomes gap in life. And it's something that I don't think we as Canadians like to talk about as much or probe as much, because there's this sort of view that we have a universal system and that everybody has access. So we're, have an advantage over the US, that if you go to emergency department, you will not be asked to show a credit card or be foot with a bill. But the reality is that people experience outside the emergency department, outside the hospital walls, are very different amongst us. And to your question, Ken, on what we're seeing with COVID-19, none of this is really shocking or surprising. We've known that there's been a disproportionate burden of disease on low-income Canadians, again, marginalized and racialized groups. And the data that was just presented yesterday by Toronto Public Health has shown exactly that there is 10 to 20-fold differences of where COVID-19 is seeing cases and deaths in our city. There are pockets of concentration of the disease, of the spread. And there really are along the fault lines of poverty, race, and housing. And so I think it's something we all could have anticipated. And it's something that we're now actively working to ensure that we can not only save as many lives through this process, this pandemic that we're all in together, but what that could look like afterwards.
You mentioned that you grew up in St. Jamestown. And St. Jamestown, for those of people who don't know, is not one of Toronto's more affluent areas. I myself grew up in Sault Ste. Marie, in a similar type of area to what you might think of as St. Jamestown here. So I'd ask, how did that help shape your perspective, and how did you get interested in medicine and then the discipline of social medicine in particular?
Yeah, I mean, I think in so many ways, what we experience at an early age impacts us in ways that may not always be so top of mind in the decisions that we make. But I do want to start by saying that I think, communities and ones like St. Jamestown are areas where there's a lot of poverty and there's a lot of, a high concentration, technically of different races and ethnic groups can get a bad rap as, rough or a hard part of time. I have a really different view. I mean, my take on this is there was the greatest blessing that our family could have had was starting in St. Jamestown. I think there was so much, and there is so much hope. There is so many stories that, again, are none of the ones that we have that make it unique. I mean, I think that there is this struggle that has been there, people wanting to do the best that they can amidst the structural forces that we come to see that really do, unfortunately, for many people, shape the opportunities that we have. And so I think for our family, we're very lucky of where, there was the ability for my dad to retrain as a physician in this country, but where those opportunities and connections and community was there to support us before that happened, had a really lasting impact, again, on just what that's like to be in a quote unquote vulnerable community. I think you really learn and appreciate the resilience and the courage. And I think a lot of that is coming out now in COVID-19 of when we've been talking about, vulnerable populations or essential workers. These are people we used to, call unskilled or minimum wage. And we're seeing where that's been maximal courage to keep parts of our economy open, to keep our healthcare delivery open, to care for our loved ones in a variety of settings. So I think really just upending some of those views of these are really essential communities. And so I think where, look back at how it shapes views of social medicine, we've seen it from where, families who didn't have some of the luck or good fortune, some of and mainly the opportunities that my family was able to have, but no different in terms of the views that we held, the talent, the skills, the hard work, just actually how fortunate how much of this is actually to chance, how much of this is actually around the system and the structures that are in place. And I think that really drove me towards medicine, not only in trying to better understand disease, but a lot of my other training in terms of health policy and health economics about the patterns of disease and the ways that these kind of decisions and these outcomes are really shaped upstream from a clinical encounter, from being able to be seen in my office, that a lot of things really are determined by how we view employment, how we view minimum wage, childcare, other aspects of how we're able to actually prescribe opportunities. And I'm so indebted and moved by my colleagues and coworkers who've been doing so much on the front line. And that includes to me, shelter staff, to nursing, to physicians, and our personal support workers, and everyone between. And I think the part of this is also really understanding that part of this is the virus, is of being able to best address what we can do. But part of it is the virus is also exposing the systemic inequities and the the pathologies that we have decided as that are tolerable as a society. So I think those pieces, that kind of background has led me to it, but also more, I think, directly in the conversation this evening, to think about what we need to be doing on a more, sort of in a bifocal sense.
Right. You mentioned the notion of prescribing, and I think that people I think people understand the general concept of social medicine, and they certainly understand the concept of medicine now. But how does social medicine actually work in practice? Like, you can't write someone a prescription for a job or a house, or better childcare. So as a doctor, in terms of the actual practice of social medicine, how does that actually work?
Yeah, it's a great question. I think it's a confluence of things. I think when you look at it, one, yes, in many ways, if I scribble a prescription right now, you're right, for the minimum wage to be $18, that piece of paper is not very helpful, or not worth what it's been written on in terms of the script or the pad. But I do think that we have to also understand our privilege and the place that have been in terms of the structural aspects I've referred to, that healthcare, as an institution, if you look at it, has carried weight and decisions around where we want to spend our dollars. If you look at provincial budgets, we spend between 40 to 50% of our budget in Ontario on healthcare. So in terms of the decision, the opportunity costs, we have as a society decided that healthcare is really important. Otherwise, we wouldn't be spending nearly half of our budget on the field and in the profession. And so I think some part of social medicine is that awareness, but also exploring those views of what the societal opportunity cost is for those dollars that are spent. And if we in healthcare don't recognize that, we can't come forward and say, actually, if what we're trying to do is best advance the healthcare outcomes of our patients, it may not be actually more prescriptions for said drug or said surgery or therapy, but it might actually be that this person might require and might most benefit from housing or from safe employment. And so there are ways that we can influence those decisions that I think has been known from the beginning of medicine. When you look at some of the early pioneers in social medicine, one of them is Rudolf Virchow, who is a German physician from the 19th century. And one of the quotes that he's had back, and one of the fathers of, one of the founders of social medicine, is the idea that, politics is just medicine on a grand scale. And when you look at Foucault on these issues of medicine, that the first task of the physician is against bad policy. And so we've seen these threads throughout history that, when medicine was not commanding 40% of budgets, that there was still this sense of importance or reverence or views, again, in terms of that relationship, that people might listen to their doctors, that might listen to science at that time, that there was a way to influence some of the decision that was happening at a higher level. So I think from a sense of social medicine, there's a sense of a responsibility of advocacy that is central to this, that is not about advocating for, more healthcare dollars per se, but actually evidence-informed ways that actually have the most impact for our patients. And that's a core tenet of social medicine. And then I think to the other piece, you're right, as a doctor, you also have to have the humility that you shouldn't be in the position and have to be able to make these decisions on your own about what the right investment is, or what people want and should have, or should be interested in. You do want to see those elements of people making their own decisions. You do want to see the element of people having their own liberties. But I do think there's a part of it where, as physicians, and in terms of that relationship, better understanding the context, the social context that people are living in, and being able to tie those threads to some of the services and other supports that are there is really important. Again, that's always a choice. That's always there to try to have that as an opportunity. I have some aversion to using the term prescribing or social prescribing, because I think that really kind of in some ways cuts at the patient autonomy. There's got to be the choice, the ability to do so. But if we're not thinking, not only about how we're spending the 40% of our budget, but also how this better integrates with some of the things we mentioned all the way back about housing, the environment, income, and better integrating those dollars and better integrating those services, I think we've failed in healthcare that way. If we do not do that, we're failing patients.
Well, obviously, it's hard for any individual doctor to write a prescription for a house or a job or anything like that. All of these things come from social policy. But in a way, UHN has done that to a certain extent. Can you tell us a little bit about what's going on in Parkdale and the donation that UHN has made there?
Yeah, so I think, this is another piece again around examining and being aware of your resources, the dollars that are there in healthcare and how they can be best spent in terms of, again, if the outcome that we're all after is actually improving the health of our patient population. And that's something that, again, people throughout this organization and others across University of Abbey, across the city and the province are really committed to. And so I think one of the things that we were able to see is that one of the most obvious areas of where we know there's a major disparity in health outcomes is for individuals who are experiencing homelessness. And again, I think for many, it's very obvious. If you don't have a safe and secure place to sleep, you cannot store your medicines, you have other impacts, there is constant stress, there is, a whole litany of things that really undermine your ability, and even if you want the choice or the interest to do so, that really cuts away at people's opportunities and people's ability to have a healthy life. And one of the things where we've seen that is obviously with homelessness. There's been studies and randomized trials to show that if, again, amazing that we're in the state as a country where we have to run a randomized trial and that you give sort of set up as a study that you give half the people something and the other half, a control or nothing at all. And we've actually had, this is where I think it's a really a moral question for us. We've actually had to run studies and say, what would be the benefits of giving half a group of people housing and the other half not? And lo and behold, if you give people housing or you're able to assure and accommodate them with housing, their healthcare costs go down, their health outcomes go up. And the most important piece for me as well, and I think for many at the table, is that there's an element of human dignity and there's an element of human rights. And I think we look at this from where the community has known this forever. The community has not needed RCTs or randomized controlled trials to know the importance of how poverty affects people in their neighborhoods, how the lack of housing does. And so with Parkdale, we were able to really, and again, I say with full humility, that we're able to catch up. I think that there's been parts of healthcare system that have done incredible work with incredible science, with incredible advances. But we've been very siloed. We've been, in some ways, focused on X part of someone's care journey, do the best that we can for that. But once they're outside of the hospital walls, it's on whomever else, or it's on whatever other community agencies or which other supports that are there. And what we saw and what we see at UHN, and it's not at all unique to our organization, is that there are a number of patients who we sort of have seen as high needs or that have been underserved, is how I would upend it, that are within our emergency departments dozens, if not hundreds of times a year. And again, you don't have to do too much of connecting the dots to figure out that many of these individuals do not have secure housing or are experiencing homelessness. And so by coupling the leadership from community, by being able, sort of my role, to look at and assess and analyze the data to see that this is a really clear trend with really big implications about utilization of the healthcare services, the spend, we were able to see that there was an opportunity with hospital land that was in Parkdale, that the community again has shown leadership around pushing for affordable and supportive housing. And we were able to take their lead to say that there was the data and the compelling stories here for us to dedicate close to $10 million in land for partnerships to be there to build more housing and provide supportive and affordable housing in Parkdale for some of our high needs patients. And sort of the journey, and we're hopeful that obviously this has been really underscored with what's been happening right now.
That's amazing. I mean, if there's one thing that I think has been drilled into all of us in these COVID times, is that there's no such thing as, you know, an individual outside of the society that we live in. And it's no sense in any of us, you know, being free of disease if the disease is still circulating in the community. And you might say that there's an opportunity at this time, perhaps more than any other time in our history, where we know that we as a society won't be safe from COVID-19 if COVID-19 is running rampant amongst our homeless population, because it's very difficult for those people to self-isolate or social distance or any of those other things. I know you spend a lot of time in the city's homeless community and in shelters. Can you talk to us a little bit about specifically what you're seeing there in the current crisis, and how you hope things might improve in the current crisis for that population?
Yeah, I mean, I think it's to recognize the privilege that I have to be able to be here tonight and have this conversation with so many leaders across the city. These are things that I really have to be aware of and mindful of, in that there are stories of people that are not mine, that I'm fortunate to be involved with, to care for however best I can or we can. And as I have, and we have the privilege to be around a table like this tonight, there are people, hundreds and thousands of people in this city who do not have the privilege of being able to physically distance, to sleep somewhere safe, to ensure that they don't feel like they are at high risk of transmitting a disease or infection to one of their loved ones or friends. And so I start with that place of humility to understand that these are the things that I'm seeing, but there's also the realities that people are living. And I think from where we've had the conversation from tonight is that, again, we've known about the impacts of homelessness, and that we actually see that homeless individuals live 20 to 30 years less than the general population. And, we have glossed that over. We have ducked it. We have been willfully blind. And to your point about what COVID-19 is doing with shelters, is it's ripping the curtain back. I mean, where if we wanted to as a society to ignore it, this has exposed it in some of the cruelest ways, with a lot of the infection rates that we're seeing currently in shelters, which we've seen in congregate settings, which we've seen in long-term care homes. And if there are individuals on the call or dinner tonight who've been impacted that way, I send my condolences. I send my my regrets as someone working in the healthcare field that we've allowed things like this to happen, and my apologies. And I think what we are seeing with COVID-19 again in the shelters is that from the beginning we were not able to adequately protect not only the residents, but the staff who've been working in those congregate settings without the adequate amount of personal protective equipment, things that were needed early on. I think there's been a really rapid and strong response from partners, from community, to ensure that people are not left behind. But when you have this against a backdrop of decades of neglect, it is really hard to turn corner together, not only overnight, but even within the matter of weeks. So we are seeing that the data is showing this, that the rates of infection in shelters are, beyond concerning. We know the deaths that primarily have happened in Ontario and the rest of the country have happened in long-term care homes. And we know from the data that came out yesterday that neighborhoods where it's challenging to isolate, where people are underhoused, where it's crowded, where there are individuals who don't have things like paid sick leave or sick days, are the ones who are being infected and the ones whose lives have been ripped apart. I'm glad that the public has taken interest in this, to have those views be told and the stories of patients and clients who are going through the system and telling those stories firsthand. And I'm really grateful for the Foundation and Toronto Life and people tonight that this is one of the issues within the healthcare system that there's concern about, and that there's hopefully more and more collective action to get us through this pandemic and well after.
So I have a couple of more questions, but I'd like to remind everyone who's on the call tonight that we're going to be opening up the floor for questions from anyone who has them. If you'd like to put your questions in the chat, as well as whether or not you would like to turn your camera on to ask your question yourself, then we will have a chance in a minute or so to ask those questions to Dr. Boozary. I think it's hard for all of us during this time. Just before we started, we were having a conversation with some of the people about just how hard it is for us all to work at home and have our kids at home and try to do our jobs from home and all of those things all at the same time. I'd like to hopefully have a little bit of a bright note here in the midst of the conversation, and to ask you, what are you hopeful about right now? Let's try to inject at least a little bit of positivity into the discussion. What is really captured your imagination right now, and makes you hopeful for the coming times?
Yeah, I wasn't saying any of it as a buzzkill. I think that we've got to be, for me especially in the worlds that you have to crisscross, but care that, you have to have that responsibility. But I think there's a lot to be hopeful about. I think there's a lot in the sense and we're the ones who have to have hope. I mean, I think, again, to the point of having, certain privilege, there are a lot of people who've been without hope, who've been denied hope for many years and for decades. And we are the ones, who have to keep on the hope that we can make things better, that we don't go back to normal, which is, again, sort of outlined. You asked for, it was your questions, asked for the roots of social medicine. They've been longstanding. The fault lines have been longstanding, so there's nothing new about it. But there is a renewed opportunity within a crisis to change our concepts of what we owe one another, of how we deliver healthcare. And I have to say, there's been some leadership from a real leader in this country who has stepped up and has seen not only the connection between housing and health, but just the realities that we need to deliver healthcare differently. And she has stepped up to allow us at UHN, for the first time in our organization's history, to actually do really tangible things about how we can better deliver care. And I think for a long part, it's been so challenging just to do, provide good surgeries, provide good clinical care, but to not have that bandwidth, that capacity, that vision about how do you tie everything together. To your point, one doctor is not going to do it alone. An organization as big as UHN will require that kind of vision, but also that kind of human power and partnership to do it. And I have been so moved over the last few weeks that leaders like herself have stepped up to say, this is not going to be the same. The way UHN delivers care is not going to be the same, that high needs patients, disadvantaged patients need to be a priority. And from where I'm sitting, from where I've been earlier this morning, to know that there are leaders in the country that are dedicated to saying those resources need to be there for us to upend the way we've usually done things, has given so much encouragement, has given so much hope that we can only change the things that we can. But even within the hospital and the healthcare institution, that we are getting that support and those partnerships to do things fundamentally differently is definitely something I'm really grateful for.
Right. I mean, just to that point, if there's one thing that's made me hopeful personally about this time, is just the rise of experts that we've seen as a society. That people like Dr. Kim or Ellen Davila, who have really stepped forward and gained a whole new prestige, I think, in society. Listening to the experts has become fashionable all of a sudden.
I think it's because you have wine and cheese. You're more optimistic than I am about the rise of the expert. Might be because I'm without any, charcuterie or cheese here. But I think that, I think that there's truth to that. But I think we also have to realize that there's also a countervailing force, right? About the fact that we've been presented with some false choices, like, the economy or public health. And I think you're right, though. There is some things to be encouraged that we've seen incredible leadership from public health officials across the country to help us get through this crisis. But we've also, this struggle is not going to go away. There are going to be forces and countervailing opinions about maybe not having to look to science, but to what might be driven by dollars or the economy over people. And I don't get discouraged by that. I just think we all have to be heartened by the battle that's ahead and that is currently happening. But I'm so glad you have that optimism where you're at and that you think that is a silver lining, and that's great. If you think science has come out on top, I'm thrilled.
I'm going to invite our members and all of our attendees, if they would like to turn on their cameras, turn on their microphones if they like, if they have a question that they'd like to put out. While we're waiting for that, I have one more question, one more thing to talk about, and that is, especially when it comes to health outcomes and the homeless, we also have an issue of policing. And earlier this year, the city dismantled an encampment under the Gardner. There's been several instances of things like this during the course of the last several years, where homelessness, more than anything, has been considered by some people to be a problem of policing. So I'd love it if you take a minute, just from your perspective, and I don't expect you to make policy or pronouncements or say anything that might get you in trouble, but I'm wondering from your perspective, how you see the police as fitting into the realm of social medicine and the type of work that you do.
No, I have no concerns about getting in trouble. I think the reality is racism is a public health issue. Police brutality is a public health issue. It is as core to social medicine. It is core to our being and our connection to people as anything else. And it is one of the most damning things that certain populations and communities have had to endure for so many years. And it is particularly hard right now this week when you see what happened in Minneapolis, when you've heard about what happened in Hyde Park just this morning for Black populations in this country, in the US. We know about the experience of police brutality for Indigenous peoples, again, for different racialized groups across the country. And as much as we've seen it as a sort of US thing, again, where we might have rested on some laurels about us having a fairer or more just society, there is no shortage of police brutality and issues of unfairness with the law in our judicial system, having serious impacts on people's life. We talk about incarceration and its impacts on health. It's a public health issue. And years ago, we were okay as a country putting people in jail for marijuana possession. And now as a country, we have people looking to become millionaires off the same thing that has changed and upended people's lives. So we cannot run from the hypocrisy. We have to own it. We have to understand and address it as a public health issue with all of the levers and policies that, you know, people have written about and known about for years, which you don't have to get into. But I think it's really important you raised it. I have felt for my colleagues who, you know, that have had to be at the trauma and the ideas in terms of the patients who've had been triggered and traumatized by their experiences in the past. And I think the one thing to end on, and maybe to be hopeful, is that we've not always understood that, and I think more generally as a healthcare system, that there is distrust of healthcare institutions. There's distrust of the police. There's distrust of the government. And if you are not from a certain race or a certain community, it may seem completely foreign and completely, you know, unrelated to issues of public health or healthcare. But I think what we have to understand is to bring that together, to understand that we cannot have these issues in isolation, and that, you know, where we can be allies, where we can come together on these issues to address, can have major changes. And I think nothing about this is new. The only difference is we now have cell phone cameras, and that this is being highlighted in very painful ways. And if we do not come with convincing action, again, we have to own that we are okay that if you are of a certain color, you have the risk of being murdered by the police. If you are of a certain background or religious group, you have the opportunity of being, you know, harassed, assaulted by whatever institution. And so back on the piece of social medicine, we have to understand that one of the vital signs of our healthcare system is trust. If you do not have trust in our healthcare system, you cannot provide any of the care that we hope for. And so that's where, you know, we hope to raise to it. And one of the pieces is about how do you, and I don't like the term empower because it goes to the idea that there is already this hierarchy or this dynamic, but how do you partner with communities to ensure that we can allow that trust and that healing to begin? And COVID-19 has raised it, but again, this is not going anywhere for a long time.
Yeah, it's fair to say that, just one question that I do have here. There's been some analysis of how COVID-19 affects different populations, different ethnicities. But it's fair to say, isn't it, that we don't think that there's any genetic reason why COVID-19 might affect one population versus another, that what we're seeing with different populations affected by COVID-19 is socioeconomic, not genetic.
You're absolutely right. The evidence would show that poverty in this city is racialized. We've seen that from every analysis. And so, and that's where, again, we're seeing that poverty is the pre-existing condition for a lot of us. And of course, there's other elements of race that play into this that, you know, there was a heartbreaking story about a personal support worker who was a Black man and had lost his life in the last week, who seemingly, you know, was discriminated against in our healthcare system in terms of how seriously they took the concerns and the issues. And he ultimately passed away. And so you can see how these issues compound and intersect. There's an issue about how if you're racialized, you may be treated and viewed by the healthcare system. And if you're racialized, what kind of employment and economic conditions you might be in that heightens your risk to something like COVID, because you may have to continue to work, whether you're a taxi cab driver or personal support worker, you are at risk. And you do not have those options to say, I'm not going to go into work today and, you know, I can call in on a sick day or a personal day and still provide for, you know, one's family. So I think it's a great piece because, you know, Ken, we see that already yesterday, that people are saying, you know, let's not release the data about the neighborhoods because that's more harmful than helpful. I think what has harmed our country, what has harmed our healthcare system is our failure to be transparent and our failure to really understand the far-reaching tenets of racism, the far-reaching grasp of poverty. And that's, I think, back to when the question is what social medicine is, that's where we can try to wrestle with that. And if we don't do it, you know, we have to own those outcomes. And if we don't actually wrestle, we're going to continue to have this, you know, that great quote that the system's designed exactly to get the results we do. And if we don't see fundamental shifts, if we don't redesign our healthcare system, we will continue to see these healthcare gaps. We'll continue to see Black, Brown, Indigenous populations have worse outcomes. And then we can't act surprised post or pre-pandemic, because there's been enough on this, enough writing, enough body of literature, enough reports, enough commissions, that we don't need more of that. I think what we need to start to see is collective action.
Well, I think it's obvious that I think everyone can feel your passion and for the work that you do. And I think it's clear to us all that there's never been a more important time than right now for the type of work that you do. This is normally where I would invite our audience to provide a round of applause. But thank you so much for all of your time today. Before we close things down and talk a little bit about what's going on with the next Serving Knowledge Supper Club, I'd like to introduce Alex Wilson. Once again, Alex is the owner broker at Remax Wealth Builders, and he's matching everyone's donations tonight. But I'd like to invite him to say a few words.
Yes, thanks, Ken. And I just want to thank Toronto Life, Ken, Dr. Boozary for taking this time, Cheese Boutique for these fantastic cheese boards for those who opted for that option. When my wife and I decided to do this, and also my business partner, Kyle, when we decided to do this matching donation, we've been struggling with how can we help during this COVID-19 pandemic, which has really exposed a lot of these social cracks and highlighted them. So, being part of the UHN and Impact Collective wise, we decided that we needed to help. And one thing that I have the ability to do is put people together and put money on the table. So that's what we wanted to do to support this effort, especially because I am in the real estate field and I profit off the transaction of real estate wise. It was very important for me, number one, to help on the side of homelessness, and number two, and as Dr. Boozary said, we're a product of how we were raised. I'm from a small town in Northern Ontario, and I feel very fortunate that this small community helped raise me, and there were a lot of positives of that. But my father also suffered had manic depression, and unfortunately, he ended up taking his own life. And I just saw hopelessness in his eyes, and he always feared he would end up on the streets. But luckily, there was family and support around him that kept him off the streets. And whenever I see a homeless person on the streets, I'm like, well, you didn't have the same fortune as I did as to get me through the days and the structure and everything like that. So to have same thing as Ken, when Kevin Smith came on, and right when we did this, when we were able all to get together, and heard this idea of social medicine. I'm like, what's this social medicine? I've never heard of this before. And talking about housing wise, and it makes sense. Structure, security, things that people need in order to get to the next stage of where their life is. I would say everyone on this call doesn't suffer from this because you're on this call. Can you imagine if you didn't have a roof over your head, or at the end of the month, someone was going to take that roof over your head? So it's something we felt very strongly about, and we will continue to support, and I hope to continue to support Dr. Boozary's efforts. And really it comes down to finding what your cause is that you want to support within the UHN network wise. And for me, it's the housing and supporting mental health wise. Joanne, who's on this call, that's actually how I got involved. Joanne, she's part of the Living Transplant Foundation within UHN, because she was a recipient of that and feels very strongly about that. So UHN is a world-class institution. I believe you're number 4, right, in the world?
Number 5. You got to be fair.
5. Number 5 in the world.
No issue when it's
number 4.
Yeah.
Number 4.
Yeah. Number 4. It is number 4. Yeah. Number 4.
Okay.
I am. Yeah. I'm going to get in trouble with the UHN team. You're right. Number 4.
And the only publicly funded one. So just big clap of hands for that, Wise. And yeah, so I would encourage everyone on the call, find your passion within the UHN network if you do want to help out, and reach out to one of the people on this call, or reach out to the foundation, because they do fantastic stuff. And the stronger the health network is, the stronger we are going to be in society, Wise.
I heard Raj's voice in there as well. Thank you, Raj.
If I can say a quick word, first I want to thank Alex. Alex, tremendous initiative. Thank you very much for all that you're doing. I think we can rally more people like you. It is absolutely amazing how we can touch people's lives and make a difference. Andrew, thank you for doing what you're doing. I mean, I've always enjoyed our conversations, whether it be in the boardroom or outside the boardroom, and thank you. You did a wonderful job. Ken, as always, you've been a great friend personally to me. And of course, this little initiative that I'm so glad that Toronto Life and our foundation have found a way to work together. And I know we can do a lot of great things to make a difference in a lot of people's lives. Thank you.
Thank you, Raj. I do. So we have a couple of late breaking questions, Dr. Boozary. If you have a minute, if you wouldn't mind taking one. I think that the whole concept of Zoom, it's a little bit harder for people to get into this, but one of the questions that people have that I'd really love to hear your opinion on is what, for folks who don't work in healthcare, what can they do to support the efforts of social medicine?
Yeah, I mean, I think, you know, and I appreciate again the support of everyone who's been here tonight to make the contribution towards the hospital, and whatever the area or discipline is of great help and of great gratitude for that. You know, I think when you look at it again, I think what we've raised is that the things are so interconnected, and so I think regardless of where someone is situated in their job and their work, in being able to understand, I think as has come through in the question, because the term was put about public policy, is that, you know, social medicine really hinges on what we can do to create and help strive towards a fairer and more just society. And I think where people on this call, again, who have incredible influence, who have made great contributions to this country in whatever field that they're in, taking this interest, advocating for communities that have been neglected, whether that's about getting more food access, whether that's about improving access to healthcare or housing. These are things that, again, can have greater impacts on one's health and one's outcomes, one's healthcare outcomes, than being able to see me in a primary care clinic. And I think that's kind of the ways where we can really come and shape and understand that about, you know, for individuals who might own businesses, what kind of benefits they have for their employees, from in terms of sick paid leave or childcare, or thinking around not just about it in terms of dental or physio, but really these social policy issues really do tie into the concept of social medicine, and that you cannot disentangle one from the other. And I think that there's ways that, again, people are running small business or large business, or being able to, again, with powerful voices on the line, advocating for, you know, fair and more just circumstances, both in this pandemic, but well after. You know, many of us are indebted to that kind of advocacy, and we only sort of encourage it.
Thank you again. Are you headed back to work, or do you get to go home at some point?
I'm here at the office, which I love that I've done a job of making it look so cozy. So that's fantastic that you weren't aware. So yeah, no, I look forward to getting home, but I appreciate, you know, you making the time, Ken.
No, thank you so much for your time. And again, thanks to everyone who was on the session today. I did want to tell everyone that our next Serving Knowledge Supper Club is going to be on June 24th. And one of my favorite chefs in the city, Corey Vitello, is going to be creating a special menu for us from his restaurant Flock on Harvard Street. And that'll be an exciting event. And I'm not sure, Chantel or Dustin, if you want to pop in, do we know who's going to be joining us from UHN at that time?
Oh, we're not. Yeah. We're not sure just yet.
That's what I thought.
Yeah, the team at UHN, Anna, there will confirm shortly. So stay tuned for updates on our next event.
Thank you so much. Thank you, Chantal. Thank you, Dr. Boozary, of course, and thank you, Alex Wilson, for everything and for your generous donation. And thank you, Raj, of course. And thanks to all the Toronto Life Insiders and the members of the UHN Impact Collective who joined us today. And I really look forward to seeing you all in person someday soon. So thanks, and until the next time, until we see each other again. Bye-bye.
Maybe we can go to your wine club.
Thanks so much, everyone. Really appreciate it. Thank you.
Bye. Thank you.